So this next category of anti-diabetic drugs include the meglitidines. There's only two drugs in this class, palaglidine and metlidine. Yeah, I think I said that right. And they basically bind to the similar receptor as the sulfonylurea receptor. So we're not going to go into this, all the binding sites, but there's a few binding sites on that receptor. Meglitidines also bind to two of those binding sites. And then the third binding site is a distant kind of potassium channel. And so when these drugs are bound to any or either of these receptors, you can see an increase in insulin secretion, of course, in the presence of glucose. And these drugs have a relatively short onset of action and a short half-life. And so the target population is kind of like the busy kind of working people that have inconsistent meals. And so, some of the patients that don't eat a good breakfast or a good dinner or something, this would be a good group of drugs to kind of put on board. And we'll talk about the differences in terms of like the timing of where some of these drugs would be best utilized. So the primary glucose target here is really kind of the post-meal glucose surge that you get from inconsistent meals. And of course, the site of activity again is the pancreas. These drugs have modest efficacy in terms of A1C reduction, only about 1%, which is minimal compared to some of the other drugs that we're going to talk about. And of course, the adverse effects include hypoglycemia and weight gain. We know that. There is some kinetic observations to be aware of with these drugs. They are highly protein bound, and they undergo hepatic changes quite readily. And typically these drugs are administered up to 30 minutes before a meal. And the main thing here is that if the meal is skipped, then the dose of this drug is also skipped. There's no need for it. You can use it for type 2 diabetics. From a chemical standpoint, there's no sulfur in this chemical, in this drug. A lot of these drugs have sulfur moieties or sulfur adjuvants that have sulfur molecules inside of them. And so if the patient has a sulfur allergy, they can't take a lot of these diabetic meds. This is one that they actually can take because it's devoid of sulfur. And then in terms of combination therapy, these drugs have demonstrated not to be effective with sulfonylureas, probably because they have a very similar binding site. More often, they're used instead of a sulfonylurea in patients that have erratic meal schedule. So, like maybe think of a police officer who maybe wouldn't get to, or a fireman who wouldn't get to eat at a specific time because they were on call. Or even maybe an ER physician. And then patients that experience frequent hypoglycemic bouts would also be probably well maintained on one of these drugs. So the advantage really comes to dosing flexibility, but the disadvantages kind of outweigh the advantages. And for this reason, you don't really see this drug used that often. It's just kind of sitting on the shelf. One, because it's expensive. Two, patients have to take multiple daily doses. If they are that busy, sometimes they forget. The incidence of hypoglycemia is actually a bit lower than sulfonylureas, and so even though it's still prevalent, it is kind of a disadvantage, but I would say maybe not less of a little bit less than a disadvantage. And so from a clinical perspective, the target population is really those patients that experience hyperglycemias after meals, and it's because of odd timings of meals and so forth, and odd caloric intake. All right, so that's kind of it for meglitidines. Not too common, but still, we need to talk about them.